Hey guys, it's Nico here, calling in from beautiful, rainy Madison, Wisconsin, where our office is located. Um, Excited to share with you a little bit of information that we put together regarding just the landscape of interoperability. Over the holidays, we were doing some strategic planning, taking a look at the landscape, and identified a few trends and a few different interesting players that I wanted to bring to the public, bring to the community, and share. It's really interesting as we look at all the different facets of interoperability in the healthcare space, where they're all interconnected and all the different players, both non-government entities, the policy side with government, as well as private companies who are trying to make an impact and do something in the space. So I'm going to introduce a framework and then walk us through the different places where interoperability exists within that framework. So the framework itself is, we call it the 3 E's, but it is really when we were looking at trying to identify how technology can impact healthcare, this kind of came out of that discussion. Healthcare really happens at the intersection of patients and providers. So when those two meet, healthcare is delivered. And that's the traditional empathetic relationship between a provider. There's also that, that knowledgeable relationship where providers are discussing symptoms and creating diagnoses and care plans. Those are the things that I think technology has the ability to impact and help improve. It's that empathetic relationship where technology doesn't have as much of an ability to directly make an impact. So that's what we're talking about when we look at technology in this space. When doctors are interacting with technology on their own, so this is like electronic medical records or other tool used within their workflows, we're really looking for software and tech to create efficiency gains within the health system and within that provider's experience. And then, of course, on the patient side, when patients are using software, maybe apps on their phone or different portals that they may be logging into, we're looking for the technology to create empowerment for the patient so they can better understand what's going on with them, be more engaged in their care, and hopefully be able to influence their actual behavior to improve their outcomes over time. So this is the general framework that we like to use to think about where technology is and different areas of interoperability within this Venn diagram. This is the ideal relationships. Unfortunately, today we see much of the opposite of this. We see a status quo that instead of providing efficiency, a lot of healthcare information technologies are cited as providing inefficiencies within care settings. So EHRs are often at blame for this, but really the old experience of provider taking notes on a clipboard has turned into a data entry activity where they're putting notes into a computer. They're also facing the computer in the exam rooms, turned away from their patients. They have to see more patients, increase their output. And so that, of course, is leading to almost a commoditized relationship between providers and patients. This is what happens when technology is implemented and created poorly. And then what all of that boils down to on the patient side is an experience that is less than ideal. It's something that may be riddled with fear and apathy, patients that are disengaged or patients that don't really understand what they're going through and what's going on in their care process. So this, of course, is the enemy of, definitely the enemy that we're going after at Redox, but also what I imagine a lot of the companies that we work with and people in this space are trying to get around. So how did we end up at this? I want to kind of talk through some of the ways that we became inefficient. There's all sorts of studies showing the various inefficiencies in healthcare. This is one of my favorite pie charts. So this is where it's estimated we waste the most money in healthcare. So $750 billion is about a third of healthcare spending annually. So what that means is if we can essentially reduce the amount of spending in healthcare by a third and not have any adverse effect on patient care, that's what these studies have concluded, if we can figure out how to drive efficiency in the system. I love this pie graph because it is essentially a bullseye for a lot of the entrepreneurs that we work with. Many of the technologies that are coming to market that we're helping to integrate are tackling one of the slices of this pie, trying to figure out how to more efficiently deliver care at the point of care, figure out which services are necessary, tackling administrative costs. Each one of these slices is a huge market that has potential to create lots of welfare gains. And so this inefficiency, these are numbers from 2012 Institute of Medicine, but it's really grown since then. So 6 years later, we're still kind of on the rise from an efficiency standpoint. Where a lot of this came from, or at least the technology adoption in our space came from, is if we look at medical records, electronic health records, and their journey to be adopted, they were really pulled across the proverbial chasm by the introduction of meaningful use, the subsidy that was introduced in 2008, 2009 time period to first subsidize the adoption of electronic medical records, and then ultimately nowadays penalize folks who aren't using them. And the reason why this is a interesting concept is that typically in technology adoption, we see this chasm between the early adopters and the early majority. So this is where a new technology is introduced to the world, and the innovators start using it. A few early adopters start getting into it. But typically there has to be a 10x improvement in that technology for it to cross the chasm. So you think of the typical examples of this, like the automobile. Automobiles existed for 30 years before the Model T was introduced by Henry Ford. Before the Model T, automobiles were bespoke, customized vehicles that were only afforded by the rich. It was a luxury item. And the innovations that the Model T brought, of course, were interchangeable parts, assembly lines, that drove prices down and quality way up, and were the innovations required to put a car in everyone's driveway across the country, rebuild the nation's infrastructure around this. And that was the innovation that allowed automobiles to cross the chasm as an invention. We've seen Apple do this numerous times with the iPod, right? If you think about MP3 players before the iPod, they were terrible. They only held a few songs. They were hard to use, hard to get songs uploaded onto them. I had an old crappy Rio thing, and as soon as the iPod came out, it was the innovation necessary to actually get the mass market to adopt it. And then, of course, Apple's done it with the iPhone and other technologies over the years. But essentially, the theory around this chasm is that we need that 10x improvement to get the majority of the population on board. EHR adoption right now, from a population density perspective, is around 97% if we include hospitals and providers. Of course, if you're not on an EHR, you're getting penalized by with reimbursements now. But really, when meaningful use was introduced, we were at the edge of this chasm, and instead of EHRs having to innovate and create that 10x improvement within their inventions, what we saw was an introduction of a subsidy that really dragged them across that chasm. So what we essentially implemented across the country were EHRs that were never designed to talk to the internet. They were developed in an era before the modern technology stack. And that's created a lot of problems downstream as far as usability goes. So the EHRs are highly, highly customized. It costs so much to implement them because you're spending a lot of resources customizing every single workflow within that organization. They are on-premise software for the most part, which are stored in the basements of health systems and data centers managed by by a central IT department. So it's a very kind of old school way of deploying software. And that never really changed. It's still how the majority of EHRs are deployed today, in a very legacy fashion. And that of course leads to a lot of the interoperability challenges we have today. Meaningful use with the subsidies, they essentially created a set of features that EHRs had to abide by to receive the subsidy, and interoperability was not a top priority on that list. There were certainly things that meaningful use supported that helped the problem, but it was not a actual requirement to be fully interoperable between systems. There was not a standard that was created and adopted uniformly across everybody. And the amount of customization that happens at each EHR makes it so that they're really a unique snowflake at each implementation. So that's kind of some underlying challenges in the interoperability space, and we'll see those unfold as we look at the different areas where that comes to play. So if we fast forward to today and we talk about what is driving the need for interoperability today, of course we have EHRs, they've been adopted, the vast majority of the population is using them, and that means that data is digitized. So we're able to start using that data to, or we should be theoretically be able to use that data to drive insights, to drive efficiencies in care, and to help with the transitions of care. Additionally, user demands are changing. So really, as our population gets older, we're seeing people who are more digital natives, or people who have higher digital IQs going into the healthcare environment and expecting a digital experience that they're not receiving through a lot of this legacy technology. Additionally, we're seeing a bunch of shifting models. So the shift towards value-based care is really driving the need for us to use data in a way that we never had before. In a world of fee-for-service, the efficiencies were about how fast can we bill for a service and then get paid for it. And that's the world that EHRs came from. In our world of value-based care, it's much more around how do we, if we're getting paid at a capitated rate or across the patient population, then our incentives are aligned to create efficiencies within that population, to focus on improving outcomes or reducing costs. So the technologies adopted to do that are newer technologies built with a modern stack in the cloud, which kind of brings us to that third bucket. When we started Redox about 4 years ago now, we talked to CIOs and CISOs at health systems, and pretty much everyone we talked to had a no cloud policy where they said, we don't use anything in the cloud. We're not going to use your software if it's in the cloud. So deal's done. We've seen a sea change over the past few years, such that even this last year at Chime, the organization of CIOs across the country, there were plenty of talks where CIOs were saying, hey, we're not in the business of running data centers. We should really be using cloud technologies to support the adoption of new technologies and the deployment of our existing technologies, so we can reduce the footprint that our IT team has and reduce costs over the organization. So there's really been a change in mindset, and there's been a change in types of technologies that are needed and being adopted that all exist in the cloud. So health systems have really turned on that and started being more open to the cloud. There's still some laggards in that space, but for the most part, most innovative health systems are figuring out ways to embrace the cloud-based technologies, to learn how to do a security assessment to make sure that they're appropriately adopting them in a way that minimizes risk. So going back to our Venn diagram here, our 3 E's framework, if we look at each of the sections, I'm going to define interoperability within each of these sections. So at the intersection of patients and providers and technology, this middle ground where actual healthcare happens, a big one here is transitions of care. So when a patient moves between various care settings, so they're going between the hospital and the specialist and the clinic and a skilled nursing facility, those transitions of care are a big driver for we need their data to follow them in those settings. There's a lot of initiatives out there focused on that in particular. If we look at transitions of care, there's a lot of data sharing networks that have been created, both nonprofit organizations like Direct Trust or Commonwealth or Care Quality, as well as private companies like Patient Ping and Medicity and InterSystems with their health share product, focusing on how do we actually help data follow patients as they move between different care settings. So the Direct Trust establishing a framework for that to happen through messaging, an SMTP style framework, kind of like a secure email for sending clinical documents or anything else between different providers. Or if you look at things like Commonwealth, we have a networked approach where they have a hub that has a locator service, so you can identify where patients are located across various care settings and then pull down documents from them. care equality, which is really just a framework as to how we exchange data. And then, going into the private company space with folks like Patient being, subscribing to a specific patient at various care settings, and some of these other guys here. One of the things I wanted to call out is the government actually has a hand in this as well. So 21st Century Cures Act is something that recently came about. We're still trying to figure out what that means and how that's going to play into the space. But essentially, it's a mandate for the ONC and HSS to figure out how to make data or help data follow patients, a common data set that is required as patients move between care settings. Joe Biden's been a big proponent of this, Uncle Joe. Yeah, so it's been a fun thing to watch. Of course, in the other kind of areas of this are really just that technology used when we look at how provider groups or health systems or whoever represents those providers are interacting with patients. And there's a lot of health systems that have a digital transformation initiative right now. So they're trying to transform the experience for a patient to be more digital first, to meet the needs of changing consumer demands. And then, of course, we have a number of initiatives like population health or remote patient monitoring that are trying to help providers better understand how patients are behaving potentially outside of their care settings to determine where the high-risk patients are so we can intervene before they turn into a high-cost patient. And then, of course, telehealth is a huge area of this where technologies to help patients and providers interact both over video or in an asynchronous manner, over chat, over different types of tools like that. So these, of course, are technologies that need interoperability solutions to perform well. For population health, you need to be pulling in data from disparate sources, from different providers, from different patient sources even across that space. So these are different areas where we need those types of tools to allow this technology to flourish and to actually provide that better healthcare experience at the intersection of these circles. If we take a look at the provider space, so providers intersecting with technology, interoperability in this fashion is really focused on the clinician experience. So, there's a lot of talk the past year or two about the quadruple aim, right? And how we added the clinician experience as a big focus because of clinician burnout, largely cited as being driven by the adoption of this type of technology. So we need to focus on what technologies we can adopt to help with that clinician experience. There's a lot of workflow automation opportunities, decision support opportunities to help providers become more efficient in their decision-making process. And then, of course, the area that EHRs have been in for a long time, which is automating a lot of the back office work, right? How do we make it so we don't need as many administrators working in that back office to actually run the business of healthcare? When we think about interoperability in this side of the Venn diagram, there's your traditional interface engine is largely the group that are providing the interoperability services around here. So this is engines who are normally exchanging HL7 messages, going between an EHR and the various other systems used internally within that healthcare organization to exchange data. So we're mapping from specs from an EHR to the specifications of a radiology system or a lab information system or a device that might be being used. So these are some of the common interface engines that are on-premise and a legacy behind the firewall at health systems. Ensemble and Cloverleaf from Infor are probably the two big ones that come up most often when we're working with different groups, but we do run into CorePoint a lot, and Orion's Rhapsody product is definitely one out there that's dominating in the market as well. So we see a lot of these legacy interface engines being used by health systems, especially larger healthcare organizations and hospitals will have one of these in place, at least one. So we've seen some organizations with 2 or 3 in place to help route messages between their EHR and the other systems used internally within the organization. And this is all, hopefully with the goal of providing efficiency within how they provide care, using tools and technology to drive efficiency gains. The other side of this is, as we look towards newer cloud-based technologies, what are EHR vendors doing to help adopt those types of tools? So we've seen over the past few years changing of business models within the EHR landscape to create what we're calling custom vendor programs, but essentially they're marketplaces for other tools to be built on top of the EHR and use data from it and integrate with it to supplement the EHR's functionality. So these are some of the ones listed here. Epic has their App Orchard that has recently, it's been announced over the past couple of years, but it seems to be really taking off recently. Athena's More Disruption Please program, it was probably the first of its kind in this category, but something that's certainly been around and in use. Cerner and their code program, as well as Allscripts developer program, with similar sort of logo situations there. But all of these are different programs where, as a developer, you can create an application, you can hook into the vendor's custom API specifications to build an application that does decision support, for instance, or some other function within the healthcare setting. They're typically used for B2B purposes, so when you're selling something to the health system, you would use one of these programs because oftentimes, I think in the case of all of these different custom vendor programs, there's a business model in place where the EHR vendor will do a rev share or something like that with you, so they can reap some of the benefits of this. So this is really what we're seeing as a business model shift from the EHR vendor space. So something that is certainly interesting. We love seeing EHR vendors open up more and become more willing to share data with third parties. And as a developer in the space, it's something that's quite exciting because it allows you to use the EHR as a platform rather than a kind of legacy system that might be sitting behind the firewall. So if we pop over to this empowerment zone where patients and technology are interacting, this is really if we're thinking about tools that patients use. So digital therapeutics is one that's definitely interesting, coming to market recently. So that's, if you think of it like a therapeutic, like a drug, but instead of it being a chemical or a molecule, it's an app. So we're seeing things pop up to allow physicians to actually prescribe applications to patients, so patients can take it home, better manage their diabetes or better manage their medication, whatever it might be. And there's different groups coming about, like Node Health is one that is actually looking at digital therapeutics and writing about them as if they were an actual drug. So doing the clinical research to determine the efficacy of these therapeutics. In this space, more broadly, we have patient engagement type applications, anything a patient might be using on their own. An interesting one here that I like to hypothesize around is the ability for patients to actually be the brokers of their own data. And that can take form in a number of different ways, but if you have the ability to pull down your medical record and share it with anyone you want, whether that's your friends and family, whether it's posting on your Facebook for everyone to see, or it's your care provider or your alternative care provider, or if you're a medical tourist, bringing it elsewhere with you, but actually being the broker of your own data. The other interesting thing here is allowing patients to sell their data or to contribute to a data bank where they can, where it can be used as part of a control group for research, right? There's great opportunities here, especially for the young and invincibles, to pull down their data and then potentially make that available and be reimbursed for it. So a way for people who would otherwise not be engaged in their healthcare data, actually give them a monetary incentive to do so. So the health record bank kind of business model is something that I think is really interesting, but something that won't be available until we actually create patient-centric interoperability solutions out there. One of the other things I think is on the brink of happening is really consumer health. It's something that, it's not a new term by any means, but it's something that I don't think really exists completely yet. Consumer health is for the most part right now, fitness applications or applications that are for kind of niche areas, but they haven't crossed the chasm, going back to our early analogy, they haven't crossed the chasm into the majority of the population. I have a couple consumer health apps on my phone, and they're really fitness apps, right? I have Mind Body for yoga, I have Pacifica meditation app, I have Strava for cycling. these are geared towards the fitness crowd, not the chronically ill or the large drivers of costs in the healthcare system. If we open up data to patients, I believe that more applications will come to market that will be able to use that data to compare it with others, to benchmark, to create models around how your behavior might actually improve your healthcare. And I think we're going to see a renaissance, well, I guess not a renaissance, but an uprising, if you will, of consumer health applications in the future as we enable this to happen. So there's some interesting players in this space around the consumer, the patient area. I'm going to list them here. These aren't necessarily all competitors. They're kind of horizontally grouped. So RX Health and Zelf are really focused on how do we get digital therapeutics in the hands of patients through a workflow that's typically kicked off by the provider side. So it's a little interesting because these are digital therapeutic type applications, but they're ordered through the provider interaction. Groups like Validic and Human API are really interesting because they are helping to pull down data from disparate devices, right? So your glucometer or your step counter or your smart devices in your home, and can we pull all of that together in a common model so that way an application developer can use those. So we see a lot of consumer type applications using these products to, to sync your Garmin to whatever app it might be. We share a lot of customers with these groups. The kind of newest ones down here at the bottom are quite interesting. So these are following along this concept of, can we allow a patient to pull down their data and utilize it in a way that makes sense for them? So One Up Health out of Boston, out of I think came out of Boston Children's incubator, but it's really an application that allows developers to integrate with it and then pull down data from any disparate source of patient data across the country. So without the consent of that health system, with only the consent of the patient. That's really exciting because you could build an app that that you can directly market to consumers and not have to worry about the B2B sales process of selling to health systems, which is one of the hardest challenges as it's a barrier to entry in the innovation in healthcare. Apple recently moved into this market. They made an announcement a couple weeks back about teaming up with a dozen health systems to allow patients to pull down their records into HealthKit or CareKit. The really exciting piece of that isn't so much that I think patients will download their data into CareKit. The exciting part of that is that Apple has a huge community of developers building applications on top of their platform that will better engage patients than the simple CareKit kind of viewing mechanism that they've created. So that's huge progress in the space that's allowed patients to start pulling down their records. A lot of this, a lot of the sentiment around it is also being driven by the government. So, I was dogging on meaningful use earlier, but really meaningful use stage 3 was a lot of it was focused on interoperability and how we can actually allow a patient to pull their records out of the medical record, allowing or enforcing software such that a provider needs to provide an API that developers can hook into and allow a patient to pull down their records. This has been rolled into MACRA, but it's something that 2019 we should see more APIs become available from EHR vendors to allow patients to directly interact with their medical records. A lot of times, people say patients don't want an API, and that's 100% true. They probably don't know what it is. They also might not know how to interpret their own data. But the exciting part here is that the developers, the entrepreneurs out there will create the experience required for a patient to interpret her data, to figure out what it means and how her behavior can influence it, or how that data can be used to improve their welfare. So that's one of the exciting things that I'm really looking forward to in the future is, can we actually use these data to directly drive consumer engagement, consumer empowerment within care? And I think there's a lot of really good initiatives out there right now that are moving the needle on that. So I'm optimistic going into 2019 next year that we'll actually see some big moves from some of these players to help create that technology stack required for a developer to create the tools necessary to empower patients. Whew. So where does Redox fit into all of this? We really see ourselves as the infrastructure required to remove barriers to entry for technologies across the spectrum. And our goal is to create a technology meritocracy. So we live below the line here in this technology, this green area that is, we don't directly interact with providers, we don't directly interact with patients, we interact with software developers. It's our job to make their lives easier so they can create the tools and products that will actually create efficiency gains in the market, create empowerment for patients, and create the environment necessary so providers and patients can focus on that empathetic relationship. One of the things we say is we want to create a technology meritocracy. And what that means is that we hope that the best software is used for the job, not the software that has the biggest sales team or the most, the most entrenched incumbents. We want the democratization of healthcare technology, and we think we can do that by lowering barriers to entry, by making it so easy that any web developer that has an idea or an experience can go out in the world and create a tool that will improve that experience in healthcare. So, what we do today is we solve this problem. This is kind of the traditional Redox web of inefficiency. But if we look at the different areas within digital health, telehealth and analytics and automation and coordination and remote patient monitoring, these sorts of things, they span all of those different sections of the Venn diagram. But current state today, without this infrastructure, they need to integrate with every one of the data sources independently. What Redox does is we've built a network to sit in the middle of that. So we provide an API that's consistent across different EHRs, different health systems, different customizations. So the developer experience is really consistent. On the health system side, where we connect once and then we manage integrations to all of their cloud-based applications. So when we work directly with health systems, we're able to we help them say yes to more things and move twice as fast for half the cost of doing it on their own. So that's kind of the overview that I wanted to talk through. Of course, today, as Redox has grown in this space, to kind of give you some logos out here, our ecosystem currently is around 500 digital healthcare applications spanning early stage startups who are getting the product to market for the first time, all the way up to very large companies who have been doing this for years and needing to really scale across the ecosystem. We're connected to about 200 health systems now. So that number grows every day as we bring new ones on. And we do them in the vein of what applications those health systems are using. So we'll bring on a healthcare organization as they're adopting technologies from the left-hand side. So it's really a network that feeds into each other. We'll work with an app developer who sells to a health system that is either on the network, and that's great, we can turn them on. If they're not on the network, we'll do the work to actually bring them onto the network so they can be used not only by that developer, but by anyone else. So we really think about integration. We've imagined it from this place of really solving a systematic approach that isn't just creating more point-to-point connections or solving some of the base level problems, but solving it kind of systematically across the industry. So that's how we think about it. But yeah, that's what I wanted to cover today. Hope it was a fun journey kind of traveling through the land of interoperability with us. And we're excited to have more conversations with you. So definitely reach out if you want to chat more, if you have any questions about any of this, and we will get back to you. But it was great. Thanks a lot. Have a good one.